Welcome to another episode of Nurse Me Through It, where we cram from the same notes we cried over and somehow still pass. Today, we're diving into everyone's favorite nursing topic: pain, physical pain, emotional pain, and yes, even the pain of charting.
Seriously, pain is wild. It's physical and emotional. It can be protective or destructive, and honestly, if you don't understand it, you're not going to treat it right.
Also, if you're thinking pain is just a symptom, think again. It's literally the fifth vital sign now.
Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So it's not just this hurts, it's also this sucks emotionally.
So it's like stubbing your toe while spiraling over a situationship. Pain in two places at once.
Exactly. It's physical and personal. That's what makes pain management so tricky.
Okay, so how does pain actually happen? Like, what's going on in your body?
4 phases, bestie. Ready? Transduction. Cells get injured, chemicals released, like histamine, prostaglandins. They activate pain receptors called nociceptors. Transmission. Signals travel from the site of injury up the spinal cord to the brain. Perception. The brain's like, ouch, this sucks. Modulation. The brain tries to calm it down by releasing neurochemicals like endorphins and serotonin and tells the body to stop producing pain-producing chemicals.
So it's like pain gossip traveling up the nervous system, and your brain decides how dramatic to be.
Literally. And if modulation fails, boom, chronic pain.
Let's talk about pain vibes, like the difference between I just sliced my finger versus this dull ache won't quit.
That's where your nerve fibers come in. A delta fibers equals fast, sharp pain. Think paper cuts or stubbed toes. C fibers equals slow, dull, throbbing pain. Period cramps. C fibers being petty.
Okay, science nerd. Give us the pain theories, but like in hot girl terms.
You got it. Specificity theory. One pain equals one pathway. Basic. Pattern theory. Pain depends on how intense and frequent the signals are. The brain reads the pattern. Gate control theory. Other stimuli, like rubbing, can close the gate in the spinal cord and block pain. Neuromatrix theory. Your genetics, stress, emotions, and memories all influence pain. Endogenous opioid theory. Your body makes its own painkillers, like endorphins during a workout.
So sometimes you don't even need morphine. Your brain is the morphine.
Exactly, but not always enough.
Okay, rapid fire. Hit me with all the pain types.
Let's go. Acute pain. Short, sudden, protective, like a post-op incision. Chronic pain. Lasts longer than 6 months. Doesn't always have a cause. Neuropathic pain. Nerve damage. Burning, tingling, shooting. Somatic pain. Skin, muscles, bones. Easy to pinpoint. Visceral pain. Organs. Deep, pressure-y, and vague. Cutaneous pain. Surface level. Sharp or burning.
And don't forget, referred pain. It hurts in one place, but the problem's somewhere else. Radiating pain starts at one point and shoots outward.
Pain is the fifth vital sign, so we assess it like we mean it. On admission. During vitals, after meds or treatment, at rest. During movement, shift change.
Okay, but how do we assess it?
Use old cart onset, location, duration, characteristics, aggravating factors, relieving factors, treatment.
And don't forget the scales. Numeric, 0 to 10. Faces for kids. FLACCPAINAD, for patients who can't self-report.
If they say their pain is a 10 while watching TikTok, you still believe them.
All right, let's treat it. What's the WHO pain ladder?
It's a 4-step plan. Step 1 is non-opioids, NSAIDs, acetaminophen. Step 2 is mild opioids, tramadol, codeine. Step 3 is strong opioids, morphine, fentanyl. Step 4 is invasive stuff, nerve blocks, spinal roots.
Start low, go slow, reassess, adjust. So, what is PCA?
PCA equals patient controlled analgesia. The patient hits a button and gets their meds. Includes loading dose, initial hit, lockout interval, safety stop, basal rate, optional constant drip.
Other options: intraspinal analgesia, epidural or intrathecal, surgical interventions like cordotomy or rhizotomy.
These aren't pain meds, but they help pain meds work better. Antidepressants boost serotonin/norepinephrine. Anticonvulsants calm nerve activity. NMDA blockers prevent nerve sensitization. Botox for migraines or spasticity. Supplements, glucosamine, chondroitin,
Let's get crunchy. Complementary and alternative medicine.
Yep. TENS, electrical impulses. Acupuncture. PENS, like TNs with needles. Biofeedback. Distraction, imagery, meditation, relaxation.
TENS is a no-go if you're pregnant, have a pacemaker, or open wounds. Don't fry people.
As a nurse, your job is to believe your patient, assess and reassess pain, give meds when ordered, use non pharmacological options too.
Undertreating pain because you're scared of addiction? Nope. That's unethical.
Addiction equals treatable disease. Withholding pain meds equals not okay. Placebos equals shady and unethical.
Okay, bestie. Final takeaway?
Pain is complex. It's personal. It's physical and emotional. And nurses have the power to make it bearable.
Know the phases, know the meds, know the scales, and most of all, believe your patients.
You're gonna ace this. Now go past that test, babe.